So a 55-year-old male patient presented with history of road traffic accident followed by acute painful retention with suprapubic catheterization done.
So Saurav, you have been called to the emergency on phone with this history. What else will you ask for?
Sir, the vitals and sir, fast reports, fast ultrasound reports.
Actually, the accident had occurred 3 months back. So patient has come with a history of accident, with a history of retention, and there has been a suprapubic catheterization done that time.
That's okay, Shubham. But suppose, Saurav, you have been called. What else will you ask for? Okay, I agree that you will want to know whether the patient is hemodynamically stable. You will want to know associated organ injuries. If he has an extradural or a splenic injury, those will take priority. What else?
Sir, pelvic fracture, sir. If suppose acute painful retention with blood admit must be supposedly a fracture of the pelvis with.
Yeah, so specifically you would ask, you said it, even though you didn't say it in the history, you will ask for a history of blood at the meatus. You will ask for whether the patient has pelvic injury or not. Okay. Go ahead, Shubham.
The next slide. The patient was already 3 months ago when he suffered a road traffic accident due to collision between two-wheelers and an auto rickshaw. The patient was conscious but couldn't stand on his own and couldn't void periurethral. Patient had pain in suprapubic region with blood coming from the urethra, and periurethral catheterization was attempted, which was failed, and hence suprapubic catheterization was done, in which 400 to 500 ml clear urine was drained.
Saurav,
yes, sir.
Would you have done the same? Would it have been anything different?
Sir, yes, sir, I would a single gentle attempt would be made for catheterization, sir.
Anything else before the catheterization? Anything else that you could have done, or anything else that people do?
Sir, stabilization of the pelvic.
No, we'll talk about urology. Everything else will be taken care of. Fracture is stabilized, patient is stabilized, all that is done. BPS come up, is conscious, all that. Let's leave that out.
Sir,
you said a single attempt at gentle catheterization.
Yes, sir.
Anything before you attempted the catheterization?
Sir, digital rectal examination would help us in identifying a high riding prostate, sir.
Anything else you would have done? Which would tell you, no, I'll not attempt catheterization, but straight away do an SPC.
Sir, retrograde urethrogram.
No, what technique could you use?
Yes, sir.
What technique would you use for the retrograde urethrogram? How would you do it?
Sir, using Foley's catheter, sir, we would inflate it in the at the fossa navicularis with a 3 ml saline. And
how will you know that is in the fossa navicularis? As you start inflating the catheter, either it will slip out or it will go in.
Yes.
So how will you do this? And if you are using the usual catheter size, 14 or 16, probably will pass the fossa navicularis even before you realize it.
8 French Foley catheters with tip cut.
What is important when we use, one is yes, we use a smaller Foley catheter or any other catheter that can be used.
No, sir, I don't have ideas.
An angiographic catheter, a Fogarty's catheter can be used because it has a small bulb. The key is that the bulb must be small.
Yes.
Okay. If we use a conventional catheter with a 30 to 50 ml bulb, by the time we inflate the bulb, the catheter would have come out. Any other modification of catheterization that you specifically use when you want to do this urethrogram in a situation like this?
No, sir. I don't know.
Anybody else wants to volunteer the answer? You've been asked to do a on-table urethrogram before proceeding.
Yes, sir. Handheld technique is there, sir. I can use an IV cannula and insert gently into the urethra and hold it tight enough so that the
problem with the IV cannula is that it might go anywhere. There is blood, things are not clear.
So in fan filling tube can be used, which can be cut, and I can use the stillet for injecting the contrast. That's it.
Anything which is less traumatic. All this is traumatic, isn't it? I just said, I agree. Smaller catheter, 8 French, 10 French, whatever catheter, angiographic catheter. What will be the difference in the initial steps between catheterization of the urethra under other circumstances and catheterization for doing a urethrogram? Or like we always do, lubricate the catheter, put it in, inflate the bulb, then go ahead and instill the contrast.
Sir.
Kamraj, are you there? Are they Kamraj, Priyanku? Okay, the important thing here at this point is that you won't use the usual lignocaine jelly lubricant, but if lubricant is required at all, you might use a little sterile saline. If we use lubricant, then the catheter will slip out very easily. The goal is to see that it doesn't slip out.
Yes.
Fine, Saurav, now
Yes,
you found a 8 French catheter somehow. You've introduced it, inflated the bulb in the fossa navicularis. What will you do after that?
We'll inject a diluted, we'll use a 50 ml syringe and use a diluted contrast with 10 ml of contrast and 30 ml of normal saline and inject it gently to look for the distraction or
what are the two techniques described in this situation where you suspect a urethral injury and want to do an ascending urethrogram? There are two techniques specifically for this situation. Either of them can be used. Anybody? Have you heard of the term incremental urethrogram?
Yes, sir. Yes, sir.
Have you heard of the term gravity urethrogram?
No.
No. Okay, what is this incremental urethrogram?
So we gradually push in a bit of the contrast and then look for the image. And if not proper...
How much contrast will an undilated urethra accommodate?
Sir, sir, don't know, sir.
Anybody?
Sir, you asked the name of the contrast, sir?
No. What is the volume of contrast that an undiluted urethra can accommodate?
Sir, 20 ml, sir.
Why 20 ml? Any reference?
Sir, it has been described in all the like textbooks. They're using 20 ml, sir. Up to 20 ml contrast can be pushed. We also want to see that contrast is entering to the bladder also, sir.
So we not want to see all this. Okay, go back and read about this. See, the goal here is not to find out everything about the urethra, is to see whether there is the intact urethral plate for us to attempt catheterization or whether we should not attempt at all. Okay, if there is a complete disruption, we don't attempt. If it's only a grade 1 disruption of the urethra with some continuity maintained, then we might attempt catheterization. Both the increment and the gravity urethrogram are meant not to over distend the urethra because a partial tear might be converted to a complete disruption or tear. You get it?
Yes, sir.
And normally it won't take more than 5 to 7 ml of contrast to delineate the entire urethra. Serendipitously, if it enters the bladder, very good. Which area of the urethra are we interested in?
The bulbomembranous.
In the perineal urethra, correct?
Yes, sir.
So as long as we can see whether the perineal urethra is completely tall or there is some continuity, we are okay. Once you find continuity, you may or may not wait for the contrast to go into the bladder, or you might do it later. Okay, read up about this because this is frequently asked when you have ward rounds. Might be asked even in a long case if the examiner is particular about these things.
Yes.
So in addition to the fact that you will do a rectal exam, before you do a retrograde urethrogram, you will look for a perineal hematoma, any urinary extravasation or into the tissues. Usually it's if there is a large perineal hematoma, it is associated with injury. So you will look for blood at the meatus, perineal hematoma, rectal exam, and a pelvic fracture. That will complete your urological examination.
Supposing you've been called, nobody else has seen, you're the first person called, how will you look for pelvic fracture?
Sir, before we pelvic compression test was being done, but now it is contraindicated, sir. So we'll get X-ray done to see further.
Again, you have to shift the patient to get the X-ray, very painful. For this, you should know which part of the pelvis is most commonly involved. Is any part of the pelvic bone subcutaneous?
Yes, sir. The pubic
We look at the horizontal rami, palpate and see if there is any disruption, if the pubic symphysis is intact. Okay?
Yes, sir.
That is the answer. So we don't do the pelvic compression test. We palpate and see. We might find it. If we don't find it, depending on how badly the patient is in retention and how painful the retention is, we may or may not choose to do the fracture immediately, the fracture evaluation immediately with X-ray.
Yes.
Okay, Dr. Manish will continue.
If you have to place an SPC in this situation, is it different from any other situation?
There may be
I have an 80-year-old man with severe prostate, which has gone through the whole cycle of treatment. He is gone into retention. I have to put him on SPC and leave. Versus this patient, whom I will be taking him off the surgery date. What should I ensure in this?
Sir, in cases of pelvic fracture, the orthopedician,
the orthopedic surgeon. What will you do different in this patient as compared to any other routinist?
Tunneled SPC will.
No. Amal?
Sir, voice is not clear, sir. The 80 years carcinoma prostate, sir.
If you have Manish is asking, what is the difference in doing the SPC, the technique of SPC, between someone who's had a pelvic fracture and you want to do the SPC, and someone who doesn't have a pelvic fracture, but SPC is required for other indications? Maybe an obstructing carcinoma prostate, which doesn't permit catheterization. You want to do an SPC. What's the difference between that situation and this, where there is a pelvic fracture?
Sir,
right,
yes, got it, sir.
Yes,
before doing an SPC, I will make sure that I should keep in my mind that later on the patient will need antegrade suprapubic cystoscopy. So it should be high enough for me to negotiate through the bladder neck. So it should be not, the insertion point should not be low enough to, it should be at the midpoint.
Done. Kamal, you made your point. Don't continue babbling. You made your point. Stop. Yes.
Okay, sir.
So the SPC should be as high up as possible because you will be doing an antegrade cystoscopy later. Okay. So, Shubham, you can continue.
Yes. Next slide. Patient had left the pubic rami fracture, for which orthopedic consultation was done and was managed conservatively. There was regular change in the SPC catheter. There is no history of any scrotal swelling, no history of fever, no history of perrectal or perineal leakage of urine. Patient is passing motion normally with no history of perrectal bleed. There is history of difficulty in getting erection since trauma, but with no any morning tumescence.
No tumescence is okay. No any morning tumescence is wrong English. No any difficulty, no any morning tumescence, no any hematuria is wrong English. Any doesn't precede that. Saurav, I have a question.
Yes, sir.
Which pelvic fractures actually require the orthopedic surgeon to see immediately? An X-ray has been done.
Yes, sir.
You're planning an SPC, but you want the orthopedic surgeon to see before you do the SPC.
Pelvic diastasis, sir, when the pubic rami, superior and inferior are both are the both are fractured.
Diastasis. How are pelvic fractures categorized or classified? There is a classification system. Please read it up. Okay.
Yes. Yes.
And based on the classification, some might require stabilization primarily. And if the orthopedic surgeons are doing stabilization, you might as well do the SPC comfortably under anesthesia when they do the stabilization.
Yes.
Tiles classification.
Whatever, read it up. Read it up, share it with your colleagues.
So, looking at the last line, what do you think has happened? Why is there erectile dysfunction associated with pelvic fracture?
There may be injury to the perineal region causing injury to the vessels the cavernosal nerve and injury to the cavernosa itself, causing a venous leak.
Very unlikely that.
Hey, hang on. Cavernosum doesn't go into the perineum. What is more likely?
The arterial injury, sir.
Okay, one is vasculogenic and the other you said is neurogenic.
Yes, sir.
Now, where does the nerve get injured? If you don't know, we'll go ahead. You can go and find out.
Yes.
Okay. Now, again, looking at this history, when you do the local examination of the penis, what is the specific finding you will look for, which could affect the outcome of your surgery?
He has come after 3 months. There is no pain. You can do whatever examination you want. You are doing a local examination.
Any nodularity or thickening felt over the penis, which was suggestive of.
This was a perineal injury. Nothing happened to the penis. In the penis, what specific examination will warn you that there may be an issue with if I do a urethroplasty? How can you make out that the glands might be ischemic?
Sir, I like to answer, sir.
Yeah.
Sir, on examination, glands will be cold, sir, which will suggest that ischemia to the glands.
Yes, relatively cold. Can be. So you have another, just bringing it out because it is another specific finding that you must look for.
After 3 months.
Yeah. Okay, I want to go back and ask Saurav again, why is this finding important if we are planning a end-to-end urethroplasty?
It is indicative of a vascular injury. So the healing of primary urethral anastomosis would not.
No, anatomical basis of why this should be important. Come on, back to you.
Sir, while doing surgery, sir, we are going to transect the scar and the artery supply will go. And if glans is cold before, then this means the retrograde supply from the glans is also compromised. So there are more chances of glans necrosis.
Yes, not glans necrosis, bulbar urethral necrosis.
Bulbar urethral necrosis.
So the distal urethra is supplied retrogradely through the glands after you have done a transection. And if you've already got ischemia, then you can have acute bulbar necrosis.
Yes.
Okay. Go ahead, Shubham. Next slide.
So there is no history of diabetes. Patient is married, sleep normal, appetite normal, bowel habits are normal, and there is no any history of tobacco or chewing.
Shubham.
Yes.
Shubham.
Yes.
You finished MBBS long ago. Why do you want to tell us that sleep is normal, appetite is normal, bowel habits are normal? If you're presenting a long case also, I don't think they will ask you to go through this whole ritual again and again. While you are taking a history, yes, everything is important. But when you're making a presentation like this, you learn to edit what is significant.
Okay.
Okay, next slide.
General examination, the patient is conscious, well oriented to time, place, and person. Averagely built and nourished. ECOG is called 0.
Again, Shubham, we've gone through this last time. You don't have to read the slide. Saurav will tell us what he finds significant here.
pedal. So the pedal edema is there. Supposedly, there is no. No, nothing significant.
Yeah, so don't miss out. There is a pulse rate of 96 per minute. We've had a discussion here where we missed hyperthyroidism in a patient because we disregarded tachycardia. So don't miss out that. The next, of course, there is an SPC in situ. In this particular patient, spine normal, gait normal is important.
Yes.
So what do you want to do now? Saurabh? While Saurav is thinking of what he wants to do, Shubham,
Yes, sir.
please don't come with incorrect spellings. Please don't use words like LAP. I have no idea what you want to say.
The lymphadenopathy.
So I don't know, no? If
I thought no laparoscope in the hospital.
So learn if spellings are an issue, just use spell check. They will highlight this for you.
Okay.
We'll do a retrograde urethrogram and a micturating urethrogram through the SPC, and we'll assess the distance of the if.
Yeah, don't go on. You want, when you're asked what will you do next, okay, you will complete the examination. They haven't given you the local findings, the rectal findings, so you will complete all that. You will ask for tests to find out the general status of the patient. Then you will ask for a retrograde urethrogram and a micturating cystourethrogram. Correct?
Yes.
Okay. Shubham, do we have that? Is there
Yes.
anything in the local examination you want to tell us?
Sir, local examination, sir, no, sir. No.
Yeah, okay. We'll read it.
Should I read, sir?
No, it's okay. So local examination was non-contributory. It's all normal.
Shubham, pelvic instability, don't comment. You're in trouble again. 3 months after the injury, you're referring to pelvic instability. And the pelvis, the bones in the pelvis are some of the best supplied bones in terms of blood flow and vascularity. It's unlikely you'll have non-healing or instability at this stage.
Okay.
Supposing you are doing a local examination again, what are the points that are important to you? Not instability. Are there any other things that you will particularly examine for? You said pubic diastasis. You would want to look for it again, isn't it?
Yeah, yes.
What else would you want to look for? Something which you might find easily, sometimes you may not find.
Sir, perineum we would like to examine
We're talking
to
of pelvic.
pelvis.
Can you make out if there is bone distraction, displacement?
Yes, you do.
Yes.
Okay, so you look for all that, isn't it?
Yes, sir.
Get an X-ray done, but when you're palpating, you'll see whether there's any misdirected bone, whether there's a gap, whether the callus that you're feeling is uneven.
Sometimes when you are doing a rectal exam, you can actually feel sometimes bone is spicule.
Yes.
Be aware of it. As a urologist also, I think you need to make sure that before you do something for this patient, that he's in a fit position for that. So you yourself after 3 months should make sure that you can flex his pelvis at the hip joint, you can put his legs up and do it all before anesthetic. Under anesthesia, you can do everything to the patient, you see, but then post-operatively, he'll be in severe distress. And a good test that you can actually do is to make him stand on one leg. It's a very simple test to do. Just try and see whether he can stand on one leg and whether he's got balance. That will tell you the strength of the gluteus, that will tell you the strength of the quads, everything. It's very important because this is a terrible muscle a terrible bone to break, So as a urologist, there's no harm in learning some bits of orthopedics because they're not going to be bothered with the pelvis. They say nothing can be done. They'll put a plate sometimes, some they won't put that also. All those plates are meaningless. They just come in the way sometimes of your operation. I don't think they cause it. There's a world of difference among orthopedic surgeons about whether they should plate these patients at all. So, just a pointer in your clinical examination because Mohan is talking about it.
Yes, good.
Carry on, sir.
Next.
Can we go back? Creatinine 1.2. Does that worry you?
Yes, sir.
Shubham again lacks spelling. And for mm cube, either you use a superscript for the 3 or simply call it cmm, cubic millimeters. Yeah, 1.2, does it worry you?
Yes, sir. That's sir. It is higher, sir.
It is within your normal lab range.
Okay, let me ask you a question on what Mohan asked you. This patient has an SPC.
Yes, sir.
Why do you think that the creatinine, if it was high, if this is a high value, let's assume that this is the upper limit of normal, why do you think it happened? He's got an SPC. Because Mohan said, are you worried? That's why I'm taking a cue on that and asking you. Suppose this creatinine was 1.3 and your lab value is 1.2. Can you give me some explanation as to why this creatinine has gone up? This fellow is still on SPC.
No, sir.
Think about it.
Urinary leak causing an increase.
Urinary leak is there. Why should the creatinine go?
It's not leaking in the perineum, it's the peritoneum.
That will be an acute problem if there is an intraperitoneal leak.
Think of bladder function and bladder.
Sir, the SPC will cause inflammation, edema that may cause.
How does the bladder react to a foreign body?
Sir, it will be inflamed with edema will be there.
So what?
So the narrowing of the urethra.
In fact, in many patients, you will find if you put contrast in the bladder, refluxes of the ureter.
Inflammation.
No, man. What happens to the bladder that causes kidney damage in any cause? BPH. Obstruction doesn't cause hydronephrosis or renal failure. What causes problems? Shubham, you want to answer that?
Anybody answer that?
Well, due to the inflammation, there will be some changes in the vesico-ureteric junction, sir, that could lead to increased propensity for the reflux.
Kamal?
Sir, due to SPC, there will be involuntary detrusor contractions.
So you may have a poorly compliant bladder as a result of the SPC sitting there. That would cause problems.
Yeah. More importantly, you have to check because many of these fellows will put a clip on the SPC for convenience and they will clip it throughout the day and then release it every 4 hours. You see, they are causing, in effect, a little bit of an obstruction to that bladder. And when that bladder is actually, we don't know how it has been traumatized due to the pelvic fracture, could as Manish said, cause a problem with its compliance. And therefore, that could be the reason as to why the creatinine is gone up. So when you see high creatinine, the first thing you ask the patient that what will be this bladder rate? Okay, carry on, sir. X-ray, PBH, what is it? PBH, X-ray?
Both pelvis and hips.
Oh, all right, okay. I'm learning a lot of new abbreviations.
I thought this was an X-ray pelvis.
Incidentally, when you do an X-ray pelvis, the lower limit is the lower margin of the pubic rami and the pubic tuberosity. So it will include the hip joint. You don't need to write hip joint separately.
You sort of quickly describe this X-ray.
This is X-ray of the pelvis showing gross bowel loading.
Is that important?
No, sir.
Baba, first look at the bone.
Sir.
You did it for the bone, not to check for bowel loading, correct?
I think we fill the bowel contents in their head. So that's the first thing they will always look for. This is a fact. Why has this been done? What are you looking for?
There is a fracture of the lower inferior pubic, left side inferior pubic rami.
Ramus.
Ramus. Singular is ramus. Look at this and look at this. This you have described.
The upper and the lower pubic rami is left.
Any other bone fracture?
And the left.
Look at the sacroiliac line on the right and on the left.
Not clear, sir.
So if it is not clear, what does it mean? If it is clear, we say it's normal. If it's not clear, what does it mean?
There is a distraction, there is a fracture. Maybe
There is a fracture. In addition to fracture, what is it? Is it distraction or something else? Look at the ala on both sides. Any change in morphology as they appear on X-ray?
Right.
Right is normal, left is rotated, isn't it?
Yes.
So there is a disruption of the posterior pelvic ring also, or the pelvic ring posteriorly. Both anterior and posterior dislocations are there, with displacement posterior being more than anterior displacement. Okay. No, stay on. Let him describe the fractures. Let him describe what are the urological points of interest.
So the bladder.
What about the bladder, man?
The bladder shadow is visible, sir, with
One of the things we were taught in when describing X-rays in our undergraduate teaching was, if you cannot see, don't make it up. If you're not sure about it, don't say it. Because you are hesitating, the bladder shadow, this, that, if it's not seen, it's not seen. It doesn't make a big difference. But what is more important to see then? In the bladder. What is more important?
The absence of something you have to comment on.
Patient
Could he have developed some problem in 3 months? He's been on SPC for 3 months. Could he have developed some X-ray visible problem?
sir, calculus. Sir,
Don't ask.
There is no evidence of any calculus.
There is no radiopaque shadow.
No radiopaque shadow.
Of the bladder. That is how you will describe, except of course that you can see the SPC catheter itself.
What are those two small little shadows there below that SPC on this? Yeah, those two. What are they?
Those are bony fragments.
Yeah, sure. They are bony fragments. Again, a point to note. Describe it. Let somebody ask you, and if you say, "Sir, it may be that, it may be this. It could be two small stones lying in the bladder. I don't know." So
Yes.
don't. You said bony fragments. Maybe, it may not be. So describe it. That's all. The important thing is to note these findings, and then the inferences can be drawn later once you have got more information. Supposing there was white pubic diastasis, are you worried about it or not? Supposing the pubic diastasis was significant. Here there is not much of pubic diastasis except for those two cracks. There is no diastasis. But if there was pubic diastasis, as a urologist, are you worried about it? That's what Mohan asked the question. From the urological point of view, look at his X-ray. You understand my question?
Yes, sir. Is it a worry if the diastasis is there before we intervene?
Is it a worry if there is pubic diastasis?
Are you happy it will help you? Are you unhappy that it will cause problems?
Sir, pubic diastasis will cause problems. Sir. The anastomosis won't be stable.
No, the bone does not stabilize the anastomosis. In fact, we do inferior pubectomy, we do transpubic urethroplasty. If it is wide open there is no bone, you can just go and access the whole urethra.
What is important about the pubic symphysis is if there is displacement at the symphysis, because that can impinge on the reconstructed urethra and give you problems. Even approach to the proximal urethra might be difficult if there is rotation and impingement at the level of the pubic symphysis, especially the lower border of the pubic symphysis. You get it?
Yes, sir.
Importantly, if you have a wide pubic diastasis, two things can be as a consequence of that. One is, after your surgery, this patient may develop stress incontinence. Number one. Number two, you may find that the bladder can herniate. So these are two things that can happen. And if you have done a transpubic procedure because you couldn't access the urethra, that wide pubic diastasis can be responsible for bad hernia, which can occur after transpubic urethroplasty.
Yes.
Right.
This is a retro-urethrogram showing the filling of the distal penile urethra reaching up to the bulbal urethra followed by a blind ending. The contrast is not seen reaching up to the prostatic or the bladder.
You want to tell us something about here at this point? So in a normal RGU also, it is not necessary for contrast to reach the bladder. But what will you see here at this area? What is that finding called?
So, I don't know.
In an MCU and an RGU, there are two nice phrases which are used in urology. In MCU, one phrase is shouldering of the bladder neck. And in the RGU, it is called coning of the bulbar urethra. These are two nice phrases which are there, which very apt description of the radiological findings. So remember that. I think people keep forgetting these. what Dr. Manish was trying to point out with the circle was the bulbar cone. It's a very characteristic radiological finding in an RGU. And many times when you do the RGU, the contrast doesn't go beyond that because the patient contracts his pelvic floor due to the effect of this. Imagine somebody pushing contrast to your urethra. Will you lie quietly? You contract your pelvic floor. But the bulbar cone will be seen nicely because there is no stricture. And many a time, because of this finding that there is no contrast going in, strictures of the urethra have been reported on RGU, which is incorrect. Okay? So remember,
Yes.
the coning of the bulbar cone is there in a normal. And you see it's not coned at all. It's cut off. You look at normal RGUs, look at it very carefully. Don't cursorily look at X-rays. Look very carefully with a discerning eye and you will be able to make these points out.
Yes.
What are the other points of interest for you in an RGU? I mean, it's not done just to see whether there's a block or no block. There are several other things, particularly those that will guide your surgery, that one looks out for in the RGU. What are those other things?
The distension of the urethra, sir.
Okay. Don't stop. Can't finish the list. See, even in the exam, don't stop after stating one fact. If you know more than that, go on, give the whole gamut. It will help you rather than get you into trouble. But then don't overshoot. Don't put in things which are irrelevant or which are not present.
Again, the absence of something here along the urethra.
The absence of radio opaque shadows.
Along the urethra.
Any periurethral leak. No, sir. Blood checks.
Can you have a stricture in the urethra also? Can you have an anti-urethral stricture also?
Yes, sir, he can.
In the PFUDD, one of the classifications is the modification of the Goldman classification is a combined anterior and posterior stricture. So an RGU helps you to identify that also. You don't know. What Dr. Manish was talking about, he was pointing the arrow along the line of the urethra. When you inject contrast and there is a block, you can overshoot or you can inject with such great pressure that contrast will start intravasating into the spongy tissue. So that is also important to note that whatever was done carefully. But even then, you can see the nozzle tip there. It is not done as a hand, somebody's hand as there.
Shubham, if it is your hand, please be careful. Your hand will be exposed to a lot of radiation like this. Over a period of time, you don't know if you'll start getting joint pains. So this is not a good idea. There are better ways of doing the RGU.
Also, just a point. Look at this pelvis X-ray. I think the fracture is seen much better now.
Yes, sir.
And you see it much better because of the degree of rotation. So this is where a CT scan scores better than in these situations. Although it looks very frightening, but it gives you a very good idea of the anatomy of what the hell is happening there. You can see a complete disruption of the obturator foramen here. You just see it very clearly seen.
Can I post him for a urethroplasty? Looks like a bulbar urethral stricture.
We need to have a micturating urethrogram to have an idea of the length of the urethra involved due to the urethral stenosis.
Okay. In addition to the length of the urethra, what other information would you like?
It is not stenosis, please.
Sir. Oh.
It is urethral occlusion. You get that?
Yes, sir.
Please don't call it stenosis.
So the first image that we do is a cystogram. Why have we done a cystogram? This doesn't tell us anything about the urethra. So what information does it give you?
When you do a cystogram, what findings will reassure you? What findings will worry you? That's the question. Why are you interested in this cystogram?
Here there is one finding which is reassuring and one finding which is worrying.
To answer this question, Shubham, I'll give you a hint. Think of what happens during the accident. What is the finding described in the accident? And when you do a cystogram after 3 months, what could be the finding that you see? A good finding and a bad finding.
The bladder is well distended, sir. There is no contrast leak.
Yeah, so the bladder neck appears closed. If there is contrast in the cystogram filling the posterior urethra, you will be worried whether the bladder neck is also incompetent and whether the patient will have urinary leak after surgery. So that is one reassuring finding, that there is no contrast leak into the prostatic urethra or whichever segment is there. What is worrying here about the bladder neck?
It is high, sir.
So what surgical implication, surgically, what does it imply to you? Displacement, you will expect displacement of the proximal segment of the urethra. Anything else you want to tell here? Again, absence of finding, standard completion of this.
Just to add to that, when you have a pelvic fracture, the classical description is a pie in the sky appearance, isn't it? The bladder has been pushed up. And many times, even after a couple of months, the hematoma, depending on the extent of the injury, does not get resolved completely. And the so-called homing effect of the bladder base towards the pelvic floor does not take place adequately. So the bladder still remains as though it is like a pie in the sky with that little appearance that is described and quite high up, even sometimes higher than this. And this is even more worrying, as Manish said, that you may have difficulty in approaching that area to get it. Because if the bladder is high, the posterior urethra also will be quite high. All right? Because it will take everything with it. It disrupts and it just moves off because the hematoma pushes it out. And if it doesn't get resolved and it remains there for a long time, then you'll have trouble. And you can encounter sometimes this hematoma if you do a transpubic in some patients, and you find that when you dissect that area, you'll still find some old blood hanging around there. So you can appreciate all that if you think of how this whole accident has taken place and how the injury has occurred.
Also in this film, since some mention it in the KUB, if you mention that the linear radiopaque shadows seem to be outside the pelvis, that would give you some brownie points. Okay, next, what do you want?
And of course, it will also help that there is no bony fragment lying in the line of the urethra, which is another worry. So to complete it, you find that the bladder is intact, the bladder neck is incompetent, the bladder base is elevated. There is no bony fragment lying in the line of the urethra.
Yeah. Avoiding cystogram showing a funneling of the bladder neck with the contrast being seen in the prostatic, reaching just at the prostatic urethra.
What is the finding there in the prostatic urethra? Dr. Ganesh referred to it.
It's high, sir.
A characteristic finding, Dr. Ganesh told you about
the
the
shouldering-
bulbar cone and something else.
Yeah, the shouldering of the prostatic at the prostatic urethra is.
Bladder neck shouldering is of the bladder.
Sorry, shouldering at the bladder neck is being seen.
So there is shouldering of the bladder neck. There is some contrast in the posterior urethra. What else do you want to tell us? Now you have to concentrate here only. Don't go around all over.
This. Yes, that's it.
Is there any lateral displacement? Is the prostate normally a midline organ?
Yeah, there is a lateral displacement, left lateral displacement. So the image can.
At this point, if I were you, I would like to go back to the cystogram and come back to this before I make a comment about displacement. There is something else you see on the cystogram. You see the asymmetric elevation of the bladder neck,
Yes, sir.
right?
Yes, sir.
It brings home the point Dr. Ganesh was trying to make, that there could be a persistent hematoma. The hematoma on this side could have been larger. And when there is a large hematoma, rotation, displacement, these are expected. They have to be anticipated. So now you go to the MCU. Yeah, look at it now and see.
Also, with the fracture being primarily left-sided, there's going to be more blood on that side and elevating that part of the bladder than the other side.
That will cause a rotation of the.
What do you want to do now? You want any more images?
You like to take one more voiding?
Yes, sir. One.
Why do you want to take one more voiding study?
You have to tell the patient to do something. You can't just ask, I will do one more and say next image. What will you change?
No, sir.
They haven't asked for any more images.
Okay.
Kamal, would you have done any more images?
Sir, I will combine, sir, RGU with MCU to know the defect, the length of the defect.
And
Sir, and sir, there is one.
Would it help to change the projection?
Give rotation. The anterior oblique is the classical position described for an voiding study.
Yes, sir. Oblique images are not done.
So that you will be able to see what's happening here. You see, sometimes the patient may void and only that bit of the urethra is seen proximally. You proceed, you fill up a little bit more, he may be able to, it makes a huge difference to you to know exactly what happens. The reason is that the commonest injury is a type 3 injury. And in many of these patients, if they've not been operated before, primary case, you will see that urethra coming down reasonably well and not stopping at this point. Because if it stops at this point, you know that you're going to be in some sort of a trouble when you operate on such a patient. Look at the RGU, put that image, put this image, and then you will see what is the gapometry index.
Saurav, have you heard the term which sir just used? No. Okay, go and read about it. Sir, can we call it off for today and discuss reconstruction?
Sure. Thank you, Manish.
Saurav can read it and come.
Yes, sir.
This whole MRI. All right.
Yeah, it's a good opportunity to read up a lot more about imaging also.
Yes, sir. Yes,
What
sir.
additional imaging can be done, and then the reconstruction part. A little accelerator will help, Saurav.
Yes, sir. Sure, sir.
When you describe this, keep going on. Huh? Okay, folks. Thank you. Thanks, Manish.
Thank you, sir. Thank you.
all.
Thank you, sir.
We'll catch up next week.